Well, good morning, everyone. Well, that was a fascinating 2 sessions, wasn't it? Where to start? David, can I just start with you and culture? Because I was one of the ministerial team. I was part of the ministerial team that started the attack on access targets. And you will know that we, by one way or another, we got the money to invest in the NHS. And the concern at the top, basically, was it would be wasted by the NHS unless there was some specific hard targets to deliver on access where, there was a patient's charter in 97, which was maximum wait for inpatient treatment, 18 months, which the health service was not delivering on. And people forget just how bad the situation was. On the other hand, in 2011, I became chair of an NHS Foundation Trust and was shocked by the culture I found in the NHS that you've described. So some mea culpa, because I think I helped create some of that culture because of the top-down targets, which we thought were absolutely essential to deliver effective patient care. On the other hand, I've seen and experienced the damage the culture that we have does to relationships and to the way we go together. I'm want to bring it back to what Ted was saying, because it did strike me that if we're trying to re-energise the NHS in difficult times, to change the culture, is patient safety an issue around which we could all unite? Is it potentially a way to sort of bring people together in a common cause that might pull some of this culture together again? I don't know. What do you think?
Well, I think it's necessary, but not sufficient. I think the patient or the citizen is critical to this. I mean, my worry a bit about integrated care is that we go back to what it was like in the 1980s and 90s, where there's a risk that the NHS providers will sit round a table and carve the budget out. And so, because if that commissioning, if the commissioner becomes weaker in this sort of new integrated world, there is a risk that the providers will become that much stronger, and there is a risk that they will just carve it up. My hope is twofold. One is that the empowered patient, the empowered citizen, with his, as I think it was Paul Corrigan said the other day in a tweet, that your phone knows more about you than your doctor does. I think that the change in the power will switch much more to the patient away from the doctor, which I think is a good thing. And I think that the patient will demand a good service and a much more prompt service. And that wasn't there when you were bringing in targets in the early 2000s. But I do think, having said that...
No, because we were acting as a kind of proxy for the patient.
You were.
In saying, actually, the NHS doesn't worry about waiting times, but the public doesn't, I guess.
And I think, secondly, you've got to have targets. I'm not against targets, except the targets become... we've forgotten the point of the targets, I think, in a way. It's hitting the target, and everyone says, hit the target, the patient died, that sort of thing. We've almost got into that mentality of hitting the 4-hour A&E target. If fact that everyone goes in 3 hours, 59 minutes or something, or you're actually admitting people who shouldn't have come into the hospital just in order to get them done before the 4 hours, is just, we know that goes on. And so I think at the time, I think you felt that targets were essential, but I think you always thought they were short term. You needed it for a period of time, and then you would bring in choice and competition, and that would take over from targets and embed improvement into the system. And I think what has happened is that targets have carried on almost unchanged for a long period of time, and choice and competition never worked.
Okay, so Ted, just thinking about what you were saying about culture and patient safety, how do you fit patient safety into this mix? Changing NHS, David has very elegantly described really the core of the long-term plan. of the funding and productivity challenge, the move to integrated care systems. How does patient safety kind of become an integral part of that?
Well, I think separating them as though they're totally distinct, I think, is the mistake.
Yeah.
We tend to find that the good organisations are good at everything. Efficiency, safety, operational performance, balancing the books. So the organisation that says we're very good on patient safety but we miss our operational targets, well, that isn't very credible. And in truth, if you do safety well, it will drive economy and efficiency, and it will drive operational performance, because there's nothing more expensive than patient safety incidents and people suffering unnecessary complications. So I don't think they are distinct, and I think they need to be part of the package. Patient safety matters a lot to patients, it matters a lot to frontline staff. And the solution to this is engaging frontline staff and patients in what we're doing. And so I think it is an essential part of that. And I think if you say to frontline staff, operational performance trumps safety, one, I think that's the wrong values, but equally, I think it actually undermines what you're trying to achieve. And the problem with, say, the 4-hour target is not that it was intrinsically a bad thing, that it came to dominate everyone's perception of quality in emergency departments. As if you're hitting the 4-hour target, you've got a good department. If you're failing to hit it, you've got a poor department. Well, if you actually go and look at what's going on in emergency departments, you can see those that are hitting the target that are not providing very good care, and those that are failing it who are actually providing very good care to individual patients. And so you cannot define the whole of quality by a target. That doesn't mean targets are not important, because actually patients don't want to wait a long time. And you know, I was in the NHS at the time when you did have to wait 18 months or longer, or sometimes several years for an operation, and I managed patients who were really very disadvantaged by that. We don't want to go back there.
So Terence, you've just demitted, as they say, chairmanship of the General Medical Council, of which I'm now a member, and you're a frontline commissioner as well. And I was really interested in Ted's just talking about some of the cultural issues around patient safety, that individual blame never really leads to improve safety of the whole system. And yet, our regulatory system is very much focused on what individuals do, their fitness to practice. And I know, you know, within the GMC, there's a continued debate, isn't there, about individual culpability as against system responsibility, and where the balance lies. And kind of thinking about the wider public safety agenda, can one run with these two horses?
So I think you're right to highlight and to think of it in two different themes. So for historical reasons, we have the regulation of health professionals, nurses, pharmacists, doctors are all individuals. They're regulated as individuals. You could change that. It requires an act of parliament. There's been both a law commission and in Ben Gummer's time, a consultation about changing that post-mid staffs to regulate teams, to address this by looking at not how doctors or nurses perform individually, but looking at when something goes wrong, as aviation would, look at the crew resource management, look at the team. That requires legislation, so we'll have to stick with what we've had for 160 years for the moment. The second thing, though, about safety is, I agree with Ted's point that exhorting individual practitioners to try harder, I don't think is the solution. And as we're here at essentially a technology conference of data, things like GS1 and other technology innovations have, like the aviation, nuclear, chemical industries, that's where we can create a fail-safe, where in fact you don't just exhort people, don't put that wrong aortic stent in again. You actually engineer out the risk by making the barcode or the font or something about it, the Poka-Yoke that Toyota used, that it just won't fit. And I think there's still a huge gain to be made there.
So that really brings me on to what I thought was a second theme of what we've heard, is that perhaps the difference between the NHS, which is a high-risk industry, and some of the other high-risk sectors of the economy is that they realised early on that you can design in, apart from kind of the clear leadership and training and imperative of a safety culture, you can design in safety features, and GS1, if you like, is part of that. I chaired the National Patient Safety Agency 2003 to 5. Those never events that you put up for 2017 look very, very familiar to the never events that MPSA focused in on in 2003-4. And at that time, we were thinking a lot about how do you design in safety. For instance, with new capital developments, is safety the paramount feature of designs in order to lessen the opportunity of mistakes being made? And when you talked about the packages for particular surgical intervention being similar, we've known about this for 20, 30 years. And I think my frustration and the question is, well, who is sorting this out? You know, who is talking, who is working with the procurement function so that as part of our much more centralised approach, we don't buy in equipment where there is is this really being gripped? That's the question.
I don't think it's being gripped because people think we've put a label on it. If people are careful and read the label, then all will be well. Right. They don't start from assumption that people will make errors. And of course, you know, stents are being put in all over the country every day and safely. You know, never events occur very rarely, but they they demonstrate the fact that we are still assuming that people are infallible and won't make errors. And that if we build our safety on that foundation, it is a weak foundation. We need to, as you say, we need to design systems that protect people and their patients from those errors. But we don't do that. We still revert back to the assumption that people won't make errors. And I think that's a fundamental thing to get wrong. Well, the other industries, you know, they said, look, stop denying errors. You've got to accept that errors occur. And you've got to make sure that you design them out of the system. You protect people from the errors. And I think that's what we haven't got right yet.
Okay, so we have David eloquently described the reason why we've ended up with a fragmented system. At national level, I think we're seeing things being pulled together. Extra statutorily, if I can put it that way, but within the limits of the statutory framework, the centre is kind of being brought back together. What I don't understand is, well, given that, who is it that should be driving the kind of safety system elements at a national level to make sure that a lot of this stuff is embedded? David, is there an answer to this at the moment, or are we working towards it?
Well, at one level, clearly the CQC has a role nationally, doesn't it? On safety. If you had to pick out one word that described the purpose of the CQC is to make the system safer. Now that it has a broader purpose than that, but safety is absolutely fundamental to that role. But actually, I mean, all organisations that deliver healthcare have this total obligation. I think Ted is right by and large. You know, that where you have great leadership, you don't just have great safety. You have great patient care. You have great operational efficiency. It all comes together. So I think without wanting to sort of pass the buck on, it does. I think the responsibility does lie with our hospitals in the main, but also with clinicians. I get into trouble from our friends in the Royal Colleges by saying I think too many clinicians, and I think for some of the cultural reasons we've discussed, have become sort of spectators a bit on this. They're happy to lob in the brick occasionally, but I think we need more of them to get on the pitch. And they should be taking, the colleges should be taking a really strong lead on safety and clinical practice and clinical pathways. In a way, I suppose when Labour came in 1997, I think the mindset was very much then, look, we're going to go to targets and competition and choice. We can't trust the clinicians. And I think we've got to go back. I think we've got to, in order to get the clinicians back on the pitch, we've got to put more trust in them as well. That's the bit I think that is missing in our culture at the moment.
Terence?
So I think Ted or David mentioned this morning unwarranted variation, and I talked a little bit about that yesterday. I think there's a great success to be grasped there. So whilst we talk about outcomes aren't as good as in the United Kingdom, perhaps other countries, we know that within the United Kingdom there's a bell-shaped curve. And some, for reasons I can't put my finger on, but clearly some organisations, some trusts, some primary care units deliver very good care and good outcomes, and some much less good. So I'm with Matthew Swindell, as that I've been saying for many years, if we could bring the bottom quartile up to the median, would be half the battle. Now, of course, there's a sort of sophistry there. I remember John Prescott being criticised for why are half the people below the mean? You create another bell-shaped curve. But just to finish, one other difference is if you look, I showed you some data yesterday about the variation in the care of children with type 1 diabetes. If you compare the United Kingdom with Sweden, not only does Sweden do better, the average, it has a very tight bell-shaped curve. So if you go across all the units in Sweden caring for children with diabetes, there is variation, but it's very, very tight. They haven't, of course, brought everybody up. There's always someone slightly better than another, but they've really narrowed the variation. And we have not only poor performance, but we have a very wide, kind of flat bell-shaped curve. And I think there's huge gains to be made in looking at how do the people who do it well, what is it they do that everybody else could learn from? Because it's one country, it's an NHS, it's free at the point of delivery. How are they doing it better than them?
Yeah. I have to say, Terence, that one thing I've learned is that all politicians, we're all united in believing that everyone should be better than the average. Which may explain why we're in the state we are. So, we're running into coffee. I just wanted to bring this back to GS1. I mean, the last 2 days, it's clear we've made a lot of progress. We know the adoption of GS1 standards can save lives and save money and can do it quickly. We also know that there are increasing signs of it being embedded in the wider standards that are being adopted. But we also come up against the sort of the NHS besetting sin, which was the reason NICE was created way back, because of the huge length of time between a new treatment medicine innovation being proven to be better than existing practices, but taking years, 15 years on average, to be widely adopted. I guess the question is, I'm now convinced that GS1 will be adopted generally, but it may take many years throughout the system. And I think the big question is there, what could we do to speed up, knowing the pressures in the system, but also knowing we don't have all the answers, but we have an offer which can bring big advantages very quickly. David, what more do you think we should be doing?
Well, it's always very tempting when you say that, is to say we should do it from the centre and mandate it. And I mean, you know, if you look at specialised,
I was trying to tempt you.
but I mean that way lies ruin, I think, frankly. I mean, it's quite interesting if you look at the uptake of pharmaceutical, new drugs. I mean, where we do, if you like, mandate from the centre through specialised commissioning, the take-up is just like that. Where it's left to clinical commissioning groups, it can take, it's very variable. But we have chosen to devolve this power down to CCGs or ICSs in the future. And now we can regulate them from the centre, we can monitor them from the centre, but actually, if we try and impose GS1, not on Derby because you've got it there, but on a hospital, they'll find ways of making it not working. And in a sense, they've got to want to do it, I think, probably. I don't think, how tempting though it is for a politician, if you were a minister again, which, who knows, may not be all that long away, Philip. God help us, actually. It may not be all that far away. It will be very tempting to do things from the centre.
Yep.
Like NP Fit, very tempting. We're going to have a common IT system for the NHS. We'll impose it from the centre. It doesn't always work out happily.
Thank you. Terence.
Well, what you're asking, Philip, is this age-old question of research into practice and the idea that it takes 15 or 19 years. A whole science is built up around behavioural change, and at UCL we have a behavioural change unit. And it really, their research would bear out what David says, is that just exhorting people to adopt things isn't going to work. I think 3 bits they would highlight. You have to disseminate it, not just think that people will automatically know. You have to provide people with evidence, which is the challenge I give to GS1. People are more likely to be convinced by proof and data. And thirdly, people are competitive. Doctors, chief executives, nurses, pharmacists. So sharing some, if not league tables, just some that these people are doing this, that bell-shaped curve, that this has been adopted here and it's done this. Often people will then want to take it on board because they see their comparators or their peers using it. And I think that's probably more powerful than being told by the minister, would be my sense.
Okay, I guess, Ted, really, it's part of a question about safety systems, isn't it, too? Well, I mean,
I suppose, this is a question as a regulator get asked perhaps more than any other question is, we've got this initiative, how can CQC help us impose it on people? And it's very difficult because, we want to be drivers of innovation. CQC doesn't want to be a regulator that gets in the way of people. We want to actually drive innovation and encourage people to innovate. But we can't tell them what to do. That is up to them. So we're looking for other bodies to set standards and to drive the process. And then when it becomes, if you like, normal, we get to that tipping point where it is expected, we can then incorporate it into our inspection framework and say, actually, this is the normal expected standard. So we're looking for opportunities to push patient safety standards. So I suppose what you need to consider is how do you get this as a widely accepted standard? Colleges, specialist societies, etc., involved in it, so that then it becomes a point at which it is widely enough disseminated that we can say, well, actually, this is what we see in the best trusts, and therefore it is part of our inspection framework for getting a good rating from the CQC. And when you get to that point, it can be built in. But what we can't do is just start from scratch and say to everyone, you've got to do this because we say so.
Right. So my sense is that we've got through the initial barrier. There is enough out there to suggest that GS1 standards wholehearted adoption can be an important part of the future development of, call it, safety systems. It's also in the procurement area as well. It can bring big advantages. It's like one more push, isn't it? One more heave, so that it's more widely recognised, and at that point, probably then recognised as being a core part of the systems that you will then inspect against.
Core evidence of good standards.
Yeah.
That's the point. I say we don't impose particular standards apart from our fundamental standards, but if there are standards out there that are accepted to be really good evidence of high quality care, then of course we'll recognise them.
Yeah. Great. Well, thank you. I think that we've been treated to a fantastic session this morning from 3 very, very key leaders of the NHS at the moment, and thank you very much indeed for your contribution. We'll go for coffee. Thank you.
Thank you.